start officially, but just kind of have these 2 slides to remind everybody where you're at. So you're at the Foundation's curriculum for targeted neonatal echocardiography and neonatologist performed echocardiography in the NHRC, Neonatal Hemodynamics Education, well, technically Curriculum Committee. And then we are supported by an unrestricted educational grant from Mallinckrodt. And I think we can actually go ahead and get started. So, so my name is Danielle Rios. I am one of 2 chairs for the curriculum committee for the NHRC. And Danny Weiss is my partner in crime over there. And so we want to welcome you, all of you, to this, our, what is it? July, August, the 3rd lecture for the year, the academic year. I think we have a great speaker for you today. So David Bailey is a cardiac intensivist boarded in pediatrics, pediatric cardiology, and pediatric critical care, and is the director of quality in the cardiac ICU at Primary Children's Hospital. He's the founder of the chylothorax work group and is interested in transforming existing data structures to be used at the point of clinical decision making. So I'm looking forward to this lecture.
Hello.
Just for everybody, just to kind of remind you also before we get started, I wanted to remind you that and I don't know if I think we explained it to you, Dr. Bailey, but so the panelists are all, you know, our co-chairs, but also all of the hemodynamics trainees from the US, Canada, and then actually I think there's even some from overseas. Who can turn on their video and they can turn on their audio. So you can actually interact with them during your lecture if you would like to do that. And then to the trainees, if you would like to do that, turn on your camera so that you can have a little bit better interaction as well. The questions, so Dr. Bailey, you can kind of talk to them about that as well, in that the panelists are able to actually turn on their audio to ask a question or to answer a question. However, everybody else is not able to do that. So anybody who is not a panelist should put any questions in the Q&A box, not in the chat box, because the chat box kind of gets overrun with other things. So in the Q&A box, and then we will try to get to those as soon as we get through all of the trainee questions at the end of the lecture. And the trainees, you can feel fine putting it in the Q&A box as well, but I think it's a little bit more interactive for our speakers if you actually ask the questions and just have that discussion. So I will turn it over to you, Dr. Bailey. Thank you so much for joining us.
Danielle, you're so kind. Thank you. It is it's really good to be with you. I have no disclosures. I do have maybe a confession. I went to NeoHeart a few years ago, and I didn't really know this kind of meeting and group existed. And I was so impressed with the attention to the importance of hemodynamics and neonates and those with congenital heart disease. And so it's really fun to continue to get to know some of you. I recognize some of these faces and names from the meeting that we just had in Anaheim. So it's great to see you again. Before I forget, I'm going to share something with you. Here's a slide that I think is just fantastic, but I'm going to add to this. This slide here, blood goes where it was needed. You could get away with saying this in 1794, apparently. And this is a treatise on how to treat gunshot wounds. In 2004, they kind of upped their ante a little bit in the Journal of American Physiology. They questioned him. He was dead, so he didn't have to account for it. But he said he must have wondered how blood knows where it is needed. And it's just kind of an interesting historical perspective of how technology as well as clinical acumen come together to help us along in understanding these things. So today, this is really meant to be interactive. This works when we work together. Golnaz can tell you that. I think she's seen pieces of this before. So if you're able to at all, turn your cameras on. I don't care what your background looks like. This is just really made to be interactive, and even interactive between you and me and each other. So put stuff in the Q&A box and let's walk through things. This is the chance to kind of ask the things. Was never really sure about this, never really quite made sense. I've heard it this way, but then I've heard it that way. Just stick them out there. Because that's really what we're going to gain today most from doing it. So my disclosure is this is how I was taught. I mean, this is not how I was taught, but this is how I learned. And it was interesting that this all came together over time. Kind of the principles that we're going to walk through today. So we're going to jump right in first with this. This is a very elegant drawing of a heart. So this is a box diagram, and box diagrams are great because it helps us really get at physiology. We don't get distracted by so much by the anatomy. Anatomy and physiology they're different. And it's important to really just say that out loud and unpack it in your head that they're different. Because what we're going to do today is to try to help you. Can you see the screen now? Who knows what does everyone know what deja vu is? Lauren, Rose, is that how you say it? What's deja vu?
When you see something you thought you'd seen before.
Yeah, you feel like, I've seen this before and it looks familiar, right? Well, today we're going to talk about, hopefully we're going to give you some Vujade experiences. Has anyone ever heard of Vujade? Vujade, you have? Rachel, did you raise your hand? Oh, she just raised her pen. Vujade is when you see something in a new way, even though you've seen it 1,000 times before, right? We've had those moments. Those are awesome moments. You're at the bedside and all of a sudden you're like, oh, I get it now, right? That's Vujade. So that's the point of what we're doing today. So again, you have cardiac anatomy, and then you have cardiac physiology. So for example, an ASD, an atrial septal defect, is not physiology. That is anatomy. Atrial level of right to left shunt or left to right shunt, that's the physiology. The anatomy helps drive the physiology, but you have the cardiac anatomy that drives the physiology, but you also have patient factors that drive physiology. Okay, so a term infant with a ductus is very different than a 2-month-old with a ductus, right? There's changes that happen. So you need to couple the patient factors, which are dynamic and changing, with the cardiac anatomy, which shouldn't change unless we do surgery. And you bring those things together and you get a predominant physiology. So today we're going to get a framework for doing that. And we're going to do that. We're going to start with doing that by talking about the ductus. So we're going to come back to this box heart here. And let's just start with normal. And can you see the whiteboard now? Okay. So if I'm going too slow or too fast, someone thumbs up, someone thumbs down, and let me know. What's the normal pressure in the right atrium? Normal pressure. You can be close, don't worry.
Like 5 to 8.
Oh, Rachel, that is amazing. Love it. 5. We're going to say 5. Is that okay? Makes it nice and easy. All right. Normal pressure in the left atrium. Let's just go to the left side here. Same or higher? Higher. All right, let's give it 8. She said 5 to 8, so we'll give it 8. Normal pressure in the right ventricle. Normal. Let's say this is kind of a newborn baby, no other complicating factors. What would you expect a normal right heart pressure to be about? Anyone? Lauren, I hear.
20.
What's that?
Maybe like 15 or 20.
Perfect. Yeah. So let's say 25 over what? What's the diastolic pressure in the right ventricle?
Five.
What's that? 5.
5.
Let's go a little higher. Let's go 10 just to make it easy. Okay. So normally a little bit higher. All right. What's the pressure in the pulmonary artery then? Now we're coming out to the pulmonary artery. What's the pressure out there? Let's say there's no pulmonary stenosis, there's no pulmonary insufficiency. The pressure is 25 in the right ventricle systolic. What's going to be the systolic pressure in the pulmonary artery? It's going to be the same, higher, or lower?
Same.
Right? Perfect. Yeah, you guys are sharp. It's got to be the same, right? There's no obstruction. The pressure is equalized in the chamber. So it's 25. And what's the diastolic pressure? Same, higher, or lower than the diastolic pressure in the ventricle?
Lower.
I'll give you a hint. It's higher. And we're going to get to why that matters. So let's just call it 15, okay? You're going from a chamber to a tube. So you're going from a compliance to a resistance sort of circulation. So it's 25 over 5. All right. What's a normal newborn blood pressure that you want to say? So what's going to be the blood pressure out here in the body, in the aorta, right as it leaves the heart? What do you want for a normal blood pressure? Please don't tell me 40 on 15.
60 over 25.
I love it. 60 over what?
25.
25. Okay. Whew. You guys tolerate some low diastolic blood pressures. I'll take it though. That's all right. That might come back to haunt us in a little bit. All right. What is the blood pressure in the left ventricle then? No aortic stenosis. Maybe there's a ductus, maybe there's not. What's going to be the blood pressure in the left ventricle? If your cuff pressure is 60 on 25. Is your
60.
systolic pressure going to be higher, lower, or the same? It's got to be the same, right? The pressure from the left ventricle is what generates the pressure in the aorta and the rest of the body. So the pressure in the left ventricle has to be the same. If it's lower, that would be really odd. You might have AI, but that'd be very, very odd. You probably have an error with your numbers. If it's higher, what are you dealing with? If it's higher, you're dealing with some sort of left ventricular outflow tract obstruction, AS, sub-AS, supravalvular AS, but there's some obstruction. What's the diastolic pressure?
A little bit lower.
Yeah, it's going to be the same, about the same as the right ventricle. Let's just say 10. We can give it 12 if you want, but 10 is going to make easier math. Okay. Raise your hand if you are comfortable and confident in calculating coronary perfusion pressure. Give me an emoji or something. I don't want to go over stuff that you already know. Oh, good. Now I can see the Q&A. I got this pulled up. Now I can see that. Perfect. Thanks. Oh, and your anonymous attendees, you don't even have to feel embarrassed in any way. This is perfect. You know, they unblind who you are to me. Your name shows up. I'm just kidding. It doesn't. It goes right to your program director. Don't worry. Should I go over coronary perfusion pressure? we're going to do this because this is really important. And then we're going to get into some more of these hemodynamics. Okay. The formula for coronary perfusion pressure is what? I'm just going to tell you. It's diastolic blood pressure. And this is one to remember. This one really matters at the bedside. And we're going to get into why this is important. Diastolic blood pressure minus left ventricular end diastolic pressure. Okay. So diastolic blood pressure minus LVEDP, left ventricular end diastolic pressure. Okay. So what does that look like for this baby right here? What is this baby's coronary perfusion pressure? What is the pressure in the myocardium, right? Let's say this is the myocardium, okay? And we've got a coronary coming off the aorta here, and it's going into the myocardium, okay? But then in the myocardium, this is inside the left ventricle here. So this is LV. And so you have blood coming from the aorta to trying to perfuse that myocardium, but you have a pressure within the myocardium pushing against that pressure head coming off the aorta. So off the aorta during systole, there's a pressure of 60 in this tube, right? And it's pushing that way. During systole, what's the pressure in the left ventricle pushing back up against that? It's 60, right? So during systole, in the left ventricle, what is the net perfusion into the myocardium? Nothing. Very, very minimal, right? Only during that short time during the cycle where the systolic pressures are equalizing or coming back down, and you're going to have perfusion to the left ventricle. Now, the right ventricle is a little different, right? Because the right ventricle during systole, what is the blood pressure? During systole, the blood pressure is still 60 because it's still coming off the aorta. But during diastole, what's the blood pressure? It's 25, right? So you still get some net perfusion into the myocardium, even during systole in the right ventricle. Now that's really important because you're intubating patients, right? And so you want to remember, like, this is kind of a safety net that you have. Even when they have low blood pressures, even when they're struggling, you can still get myocardial perfusion into the right ventricle. And so you might want to just optimize that in every way you can to limp it along. But so now during diastole, let's do the left ventricle during diastole. During diastole, what is the blood pressure going in? Someone in the chat box. Perfect. It's 25, right? And then what's your LVEDP, or the pressure against it in this patient? It's 10, right? So it's 25 minus 10. Your coronary perfusion pressure is 15 in this infant. You are skimming the treetops. We like at least 15. We normally like 20 or 25 for a myocardial perfusion pressure. In order to maintain enough myocardial perfusion that you don't get ischemia and arrhythmia and other issues, you typically need that. Thanks, Priya. Yeah, very good. Perfect. And so this comes into play because when you have different cardiac lesions, you can actually alter the diastolic blood pressure and the left ventricular diastolic pressure by doing things like intubating, sedating, giving them pressors. All these things alter these hemodynamics, and this is what we really need to keep in mind as we're changing the hemodynamics on these patients. What's a normal mixed venous sat? Just to really drive this point home. So if I draw, let's say this is the coronary sinus. It comes back behind the left atrium. You know this by echo, and then it kind of opens up into the right atrium. Let's say I put a catheter right there, and I draw a blood sample out of the coronary sinus. So I'm essentially sampling the venous return from the myocardium. So this is a mixed venous sat of the heart itself, right? An isolated mixed venous sat. What do you think it would be? A normal one is 75 to 80. That's what we say, right? Good. That is exactly right. 75 to 80 is normal if I draw it from the SVC or from the right atrium. From the coronary sinus, you're going to get down sometimes into the 30% range. Okay. It's really low. The myocardium is very, very greedy. Okay. And beat to beat, it takes that. It's not this big transit across an entire organ system. It's every beat. It demands a degree of oxygen delivery that is high. And so it's extremely vulnerable. And so we want to do things to make it not consume as much or to deliver more, to give you the stability you need to get through things like intubation, procedures, putting in chest tubes, repairing the diaphragm, all these other things. All right. So that's a little bit of normal. And these things are important to keep in mind. Okay, now let's give this patient something you all know and love. What is this supposed to represent? This is not a trick question. This is just to see if you can interpret my artistic inabilities here. Yeah, this is the ductus, right? I want to kind of maybe reframe a little bit your thinking about a ductus, okay? A ductus is simply a connection between the pulmonary and systemic circulations. And sometimes we get a little intimidated by single ventricle patients and their anatomies, but we're going to go through some things today to show you that they're really not that intimidating at all. In fact, I joke around, I say, you know, if I just cover this thing in Gore-Tex, it's a BT shunt, right? That's all a BT shunt is. It's just an artificial ductus. Physiologically, they behave in the exact same way. And so, so my first question is, what determines shunting at the ductal level? Okay, what determines shunting at the ductal level? And what I mean by that is this. Blood comes, let's see, we got a, blood's gonna come in, right? Coming into the left atrium or the right atrium, right ventricle, to the PA, to the left atrium, to the RV, comes out the aorta, it gets to the ductus, right? How is it going to decide if it's going to go down this way or across the ductus and over to the pulmonary circulation? We have some answers in here. Length does play into this. The aorta pulmonary pressure gradient, pressure plays into this, but Renee nailed it. It is resistance. It's the difference in resistance between the two circulations. And this is critical to decouple in your mind the difference between pressure and resistance, okay? So what is the formula for pressure then, right? So the formula for pressure is just, it's a change in pressure over a change in flow, right? So we call it delta P over flow, all right? So what this really means is, let's calculate the pressure in the pulmonary circulation. So you do a P1 minus P2, pressure at the beginning of a vessel, a circulation, an organ, but the one at the beginning and one at the end. That's all you do. So the pressure at the very beginning of the pulmonary circulation, and we usually use mean pressures. And so let's say the mean pressure between 25 and 15, let's say it's 20, okay? So the P1 at the beginning of the pulmonary circulation is 20. What's it at the end? Well, our best guess is back at the left atrium, right? Because it's gone through the lungs and it comes back in, the veins drain into the left atrium. So that's the end of the pulmonary circulation. You've included the arterial side and the venous side. And that's the beginning and the end. So it's 20 minus 8. And what's a normal cardiac output? Normal is somewhere between, depending on where you live and your units, but we're going to say a cardiac index of somewhere between 3 and 5 is normal, okay? So let's say 3, okay? So the resistance here is, and if you're okay, we can even change this to 5 just to make it a little easier. 15 divided by 3 PVR is 5 in this patient right here. Okay. What's normal PVR? Normal PVR is less than 3 Woods units. Okay, so this resistance is high in this patient. We could have predicted that though. Let's change this to 8. Then what does our PVR become? Anyone with a calculator? Yes, resistance, length, and viscosity. Those all have to do with the resistance through the shunt. That is perfect in the chat box here. I just saw these. So there's 2 types of resistances. There's resistances in the circulation, which is what we're calculating right now. And then there's resistance through the shunt itself, whether it's a ductus or a BT shunt. And that is Bernoulli's equation that you're using, length, viscosity, resistance. Perfect. So let me get 20 minus 8. What does that give us for a new cardiac index? 20 minus 8 divided by 3. Now our PVR is 4, right? It's a little more close to normal. But this is how you calculate resistance. All right, let's do it one more time on the systemic side. No one calculates systemic vascular resistance, hardly ever, except we do it all the time in the cath lab. It's interesting, when I ask a cardiac fellow who does caths all day long, I say, what's the normal PVR? They're like, it's less than 3. I said, what's a normal SVR? And they stand there and go, we just ignore it, which is fascinating to me because this is what we spend the bulk of our time modulating, right? You sign out blood pressures. We don't really care about blood pressures. We care about the resistance. I think the day will come when we will sign out and we'll say, the patient had a systemic vascular resistance of 10 to 20 is normal. We started norepi and now it's up to 15. And the cardiac, perfusion pressure increased by this. We're going to really hit at the physiology. So in this patient, let's say it is 30 for a mean minus, go through all the circulation, the arterial, through the organs, the venous side back to the heart is 5. 30 minus 5 divided by 3. What is that? 25 divided by 3, that gives you about 8 or so. So this patient has a low systemic vascular resistance and a higher pulmonary vascular resistance, which is kind of what you would maybe expect in a kid like this. So the point of this exercise isn't necessarily for you to remember this equation. I doubt you'll even see it on board. You may see a calculation of PVR, but it's to show you that normal is quite different on either side of the circulations, okay? Normal on the right side is less than 3, and normal on the left side is 10 to 20. So if I tell you that, Lauren, you have a question.
Yeah, where did you get the 34 for the S1?
Oh,
I'm assuming you're doing
question.
S1 minus S2.
I was using the mean. I was just kind of calculating a mean in my head.
Okay, so you
obviously
would, it's the
exactly 30.
mean that you use then,
Yeah.
not the systolic. Okay.
So you can see the resistance on the left side is much higher than the resistance on the right side. Okay. So this blood is obviously going to favor going through the ductus this way, right? Back through the ductus, back to the left side, back to the left side, back out the aorta, back out this way, back out this way. Okay, we got this? So if you have a ductus that is hemodynamically significant, what side of the heart will enlarge? The left or the right? The left, right? That's where all the flow is. So when we get an echo on a kid and we're worried we extubated them and they fell and they were tachypnic and they were heaving, they have a ductus and we're wondering if it's hemodynamically significant. If you don't have left side enlargement, it gets a little fuzzy of whether or not it's truly hemodynamically significant, right? Because it's not volume loading the heart to the point of causing any sort of significant dilation. So shunting at the ductal level is determined by the relative resistance, okay? Relative resistance. When does it occur? When does the shunting occur? Systole, diastole, or both?
Both.
Both, right? Okay. Systole and diastole. What is the importance of that? Why does that matter? What's the impact of a shunt that occurs during both systole and diastole? Caroline, I think you're talking, but I can't hear you. Yeah, it's more volume. And you also have what you call diastolic runoff, right? Will affect CPP. Perfect. So these diastolic shunts, they really, really hammer the heart with volume. What's the PA pressure in a kid with a ductus? What's this child right here in this box? What is their pulmonary artery pressure? High, low, or normal? Caroline, I still can't hear you. Sorry. I think you're talking. We're going to talk about a big unrestricted ductus. So it's going to be 60. It's going to be the same. The pressure in the aorta equalizes through the ductus minus whatever severe resistance you may have, but we're saying there's none. So the PA pressure is 60, okay? QP, you guys know the term QP? QP is flow, okay? What is the flow through this ductus? High, low, or normal? Is the pulmonary blood flow high, low, or normal?
High.
High. Is it higher or lower than a VSD? Let's say you have a VSD. VSDs, the shunt in a VSD is also determined by the relative, not pressures, but resistance, okay? So if you have a wide open VSD, what's the right ventricular pressure? 60. What's the PA pressure? 60, right? So both of these lesions have the same PA pressure, okay? So let's do this as a PDA and this as a VSD, okay? So here the PA pressure is still going to be 60. The QP is going to be high. Is it higher, lower, or the same if you have a VSD?
Lower in VSD.
Lower in VSD. Why do you say that, George? Jorge or George? Sorry.
Because it is not continuous flow. PDA is
Perfect.
continuous.
This is a systolic shunt, right? So the QP is not nearly as high. So, and this makes sense. A kid with a big ductus, they're going to go a few weeks and then they're really going to have issues, right? You can have a kid with a big VSD and they go for months before they congest and have all these other issues. And this is why. This is the impact of a continuous shunt versus a shunt that only happens during systole or one portion of the cardiac cycle. All right, what about the PVR? Let's say this is just a 2-week-old, okay? Their native PVR should be nearly back down to normal by now if they're a neonate, but they have a ductus. What is the PVR in a kid with a wide open ductus at 2 weeks? And we'll make this VSD like, we'll make them like 4 months, okay? PVR is high, low, or normal?
High.
2 weeks. High? Maybe. It might be, it might not be. Their PA pressure is going to be high. Their QP is going to be high. Probably by 3-4 weeks, their PVR will start to go up. But typically, if we have a 2-week-old with a wide open ductus, we don't need nitric and sildenafil and other things like that to control the pulmonary vascular resistance if we take the ductus out of play, right? Like, is it usual for you to see someone take the ductus out, stent it, ligate it, or whatever, and then they need nitric oxide right afterwards if they do it during the first few weeks or months? We typically don't see that. And let me just kind of talk through a little bit about how I think about pulmonary artery pressure and pulmonary vascular resistance. And again, this is another physiologic condition that you want to decouple in your head. Decouple things from pressure. Pressure is a single phenomenon, but it leads to resistances, which is more important. So I view this as PA pressure. The pressure that the fluid is existing on the wall of the vessel, okay? That's pulmonary artery pressure. It's 60 if you've got a wide open duct. It's the same as the blood pressure. But your, doesn't like to go that direction. But the pressure that the vessel itself is exerting back on that fluid. So imagine this is a vessel that's kind of thick now and hypertrophic. It's grown because the vascular resistance has been high from flow for a long time. And this vessel wall thickens up, right? That's resistance. Resistance is what pushes back up against the wall. And so high QP and PA pressures develop high resistance. But let's say, when would you think a ductus would get high resistance from a ductus? How old do you think they'd be when that would happen? Can we say a month? Is that fair? 2 months? So we'll say your PVR is elevated around, let's say 2 months. Whereas when you have a VSD, how long can you have a VSD before your vascular resistance, not your PA pressure or your QP, but your vascular resistance is actually prohibitively high to repair that defect? You've got 6-8 months at least, right? Lauren, your hand is up. I think it was just from before, but if it wasn't, I'm sorry. So you can see the difference between these continuous shunts and these non-continuous shunts. It's at least 6 months. So you got to pay attention to them. So the two big impact is PVR and diastolic blood pressure on these continuous shunts. Okay. All right. We've gone for like 40 minutes now, just getting some basics, your head wrapped around some things. We're going to build on these basics just a little bit now, but as we do that, questions, because we're going to talk about a coarc next and how you manage a coarc using these simple fundamental principles that we just talked about. Any questions? Okay. I know you all know what a coarc looks like, right? I'm sure that's not a surprise to you. The coarc is a pinch somewhere in the arch, and it's usually just before the ductus, okay? But I want to draw this here just so you can see clearly the anatomy again. So here's your aorta, here's your head and neck vessels, here's the coarc, here's the ductus that then feeds the lower half of the body. Here's a little video of it coming through here. Sidebar, love sidebars, right? Now everyone pays attention, it's so interesting. You come for a lecture, but you pay attention for a sidebar. I do anyway. Is the newborn screen, the pulse oximetry screen, sensitive in picking up patients with aortic coarctation? Is it a good screen for coarc? The most common lesion that we're going to see, is it a good screen for coarctation?
No.
Yeah, George, it's not. It never was intended to be. It's a poor screen for really all of these left-sided lesions, which are common. It helps detect lesions that mix or lesions with severe right to left shunts where you desaturate, things like that. But a coarc, it may not pick up. So don't be too reassured by a normal pulse oximetry screen. I'm sure you already know that. All right, so let's give our little friend here a coarc. This is gonna be fun. Love giving people anatomic lesions. Here you go. How's that? Ugh, that's terrible. There you go. There's a coarc. Can you see that? Okay, so here's the call. You've got a coarc. You've got a coarc. They call you. The blood pressure is 65 on 40. 65 on 40. And they're an outside hospital or they're in their unit, it doesn't matter. And their SAT is 83%. Okay. They're in room air on 83% with a good blood pressure. You just started PGE. You got an echo after you started it. And the ductus is small and it's bidirectional. Okay. What do you do? They want to know what you want to do about this SAT of 83%. Patient looks okay otherwise right now. No one likes 83. If I said 88, you might feel a little more comfortable. Where were the sat and blood pressure taken? Perfect. So pre and post ductal blood pressures were taken. You have a 15 millimeter mercury gradient, systolic to systolic gradient from the right arm to the left leg. So you have a real gradient there, but you're not surprised because your ductus was small and you're getting it opened up. And the sat was taken. It's the same in the right hand as it is the left foot. It's 83, dipping to 81 in both places. Does it bother you a little bit? Don't love it, right? You're not like freaking out, but you don't love it. Lauren, what were you going to say?
No, just that. It bothers me a little bit. I'd like it to be
Right?
better. I'd
Yeah.
probably want another time point to see if it's getting better on its own or getting worse or staying the same before I do something about it at 83.
Yeah. So let's say they kind of retake it again a little while later. The one in the head's, 4 or 5 higher, but the feet is now 79. So in your head, you're like, mid to high 80s. Your feet, you're now 78 in your feet. You've got an x-ray. It looks reasonably clear. There's no other, I'll just tell you, there's no other pulmonary disease going on right now that you have to deal with. And you're still kind of working on getting this ductus. Turns out the nurse had the IV clamp. He forgot. And so you're not quite sure how much PGE they got. And so the RT decides to put this kid on some nasal cannula, put him on 100% oxygen while they're calling you, because the sats are now in the 70s. And so they put him on some oxygen. Sats come up. Now your sats are in the high 80s, upper and lower. And you retake your cuff pressure, and now you're 40s on 20s in both your upper and your lower extremity. 40s on 20s in your upper and your lower extremity. What do you think happened?
I think the duct is closing and the PGE either isn't getting to the baby or needs to be a higher dose. And you gave oxygen.
Yep. So you definitely worry about the ductus closing, right? Your PGE not getting to the baby. Your diastolic blood pressure went from 40. Remember, I gave you 60 on 40 to 40 on 20. So your diastolic blood pressure dropped by 20 points. Would that imply that the ductus is opening or closing?
What's interesting is that the pre and the post ductal diastolic blood pressure are the same. If it was just the post-ductal diastolic that was changing, I would think that your duct is open and predominantly more left to right, and maybe you have some diastolic steal. It confuses me a little bit that they're the exact same.
That your upper and lower diastolics are the same?
Mm-hmm.
Yeah, so that's a good point. So the diastolic blood pressures in a coarc are often, the diastolic pressure is often not that influenced by the coarc. It's really systolic to systolic gradient that we see. The fact that the diastolic's dropping is at least implying or should make you think that you do have runoff, just as someone mentioned. So the ductus is probably opening. And so you do have more diastolic runoff through the ductus. But someone wrote in here a very smart comment. You needed the right to left shunt to perfuse the lower extremities, but now you've lowered your PVR with oxygen and lower amount of the blood going to the legs. You've also lowered the amount of blood going to the brain and the rest of the body, right? Because you have your QP is higher. You've dropped your PVR, right? So what you want is to promote a right to left shunt. If you give them oxygen, you've created a left to right shunt. So now you will flood the lungs. You will lower the amount of total blood going out to the body by giving them oxygen. So in these coarcs, what would have been another reasonable maneuver to treat this lower saturation? Do you want to leave it in the 70s? I don't. I tolerate pretty low sats. I extubate Glenn's with a sat of 68, 69% and make people really nervous, and they pink up. And I don't like a sat of 71 in the coarc, 75. So what else can you do? So let me ask the question another way. How can you get this patient closer to FRC, right? Without dropping the pulmonary vascular resistance. Or, so what you're trying to accomplish here is you're trying to accomplish three things, and you may not be able to accomplish all of them. You want the patient to ventilate at FRC, right? Because that's going to give you the optimal afterload to the right ventricle. You could try to raise your PVR. You could try to do that, but that's kind of an exercise in futility, right? We try this, let them be a little hypercarbic. We used to bleed in nitrogen. What we found is it doesn't work very well because you remember the mixed venous sat in the coronary sinus was so low. By giving them subambient oxygen and doing those things, you've outstripped the oxygen need of the myocardium more than you actually raise the PVR and get a benefit from it. You can try to lower the systemic vascular resistance, right? Put them on nitroprusside or nicardipine, see if you can promote a right to left shunt by lowering their SVR. But nipri, nicardipine, that doesn't feel good when you're 40/20. Doesn't feel good to me. You could give them some fluid, but their QP is already high. So you don't want to flood the lungs even worse than they are, because now the burden of the diaphragm is going to have to bear even more of the weight. And we know that the neonatal diaphragm already bears all the extra weight because they don't have extra thoracic muscles and a rigid chest wall. They do glottic stopping, laryngeal braking, all these other maneuvers they do already to make up for the fact that their closing capacity is lower than ours and their apneic reserve times are lower. So the answer is actually really, really simple and straightforward. This is a kid that just needs some positive pressure. Put them on CPAP, put them on high flow, just put them on a little bit of something with no oxygen. So you don't change the PVR, but you support the respiratory mechanics, open up the alveoli a little bit, and then the shunt will start to do what it does, what it needs to do, which is shunt back to the body as the PGE goes on. Because what does PGE do to your systemic vascular resistance? Drops it. PGE in and of itself is a venodilator. It is going to drop your systemic vascular resistance to some degree. So you need to remember, anytime you have a ductus or a VSD or anything, you put on PGE, you're going to promote shunting to the systemic circulation. Lauren, you have a question again?
Yeah, so I know that PGE is a pulmonary and a systemic vasodilator. Is there a dose dependence with that you see more pulmonary vasodilation over systemic or vice versa?
You know, that's a great question. I don't think I can answer that definitively. I feel like it's more of a systemic, but that is only clinically at the bedside. And usually we're dealing with kids whose PVR is already normal. And so the PVR isn't necessarily impacted. I mean, you could take it from 3 to 2, but clinically you don't see that much of a difference. You guys probably see it more with all your neonates with TTNB and mech aspiration.
Yeah, and back when they used to use, I think, PGE before nitric was readily available. And so we talk about that, but I just wasn't really sure where on a curve that actually lands and how much do I need to worry about it being PVR reduction versus SVR reduction.
Yeah, I feel like in this circumstance anyway, you're going to see more of an SVR reduction because your PVR is fairly normal already. And usually this is what we see is more runoff. Often when I start PGE, I give the kid 5 or 10 per kilo of fluid almost preemptively because I know I'm going to venodilate them with the PGE, right? So I've markedly changed their ability to preload themselves. So the venous capacitance is 20 times greater than your arterial capacitance. That's just normal. And so often we talk about vasoconstrictors. Really what we're doing is we're venoconstricting and we're venodilating by and large. And that's why you get so much bang for your buck out of doing that, is because you can alter it by 20 times more than the arterial side. All right, questions about this ductus and in a coarc and how to manage a coarc in this situation. So let's say the kid is intubated now. He's intubated. His SAT is now still 75, upper and lower. And he's on, let's say he's on 30% FiO2. Okay, and his blood pressure is now 45 on 25. The ductus is wide open. You're on a PEEP of 6, you're getting tidal volumes of 6 per kilo. What's your next maneuver for these sats? You sit on them, more oxygen. So the answer is exactly the same as before. Take his PEEP up, right? Inflate him, recruit him, oxygen him, take the PEEP up, take the eye time out a little bit, maybe give him a little more tidal volume till your sats come up a little bit more. You can get a handle on the ductus again and get a pre-post-ductal sat. But if you're in the 80s and your lactate's fine and your peeing and your end-organ perfusion's fine, you can let it be. But when I intubate a coarc, if I'm intubating a coarc, it's usually because they have some degree of dysfunction. And so those are the kids. I'm a low PEEP guy almost all the time for every cardiac lesion, unless it's a left-sided lesion with myocardial dysfunction. And then I just stick them on a PEEP of 7 or 8 right up front, just to support that myocardium. Use the ventilators, a poor man's VAD, is a poor man's ECMO, right? Offload that ventricle by giving them a little bit of PEEP, helping the transmural wall pressure be a little bit more normal, decrease the myocardial oxygen consumption. Because the reality is they'll tolerate low sats until their myocardium is ischemic, right? This whole idea of a respiratory arrest, is there such thing as a respiratory arrest? I mean, is there really? There's really not. There's a respiratory induced myocardial arrest, or there's a myocardial induced myocardial arrest. But it ends in arrest, which by definition means the heart stopped. So it's funny that we kind of put them in these buckets. A respiratory arrest is a myocardial oxygen deprived heart, rather than a heart that was just stressed or had too much afterload or had too poor of output to perfuse itself. So it goes back to this coronary perfusion equation. I've given you some thought about the optimal coronary perfusion pressure, but I've not talked about the volume of blood going to the myocardium, right? And those are different things. And this is why I keep going back to separate pressure from resistance. Resistance is the combination of pressure and volume to optimize a flow, right? And whereas you need both. So some kids don't have very much. If you give a kid a heart rate of 240, how much coronary perfusion volume are they going to have? Very little, right? They don't spend hardly any time in diastole. And as your heart rate goes up, you actually spend more and more time in systole and less time in diastole. It's not a one-to-one linear curve. And so they might have a blood pressure of 80 on 40. So their coronary perfusion pressure is adequate, but the volume of blood going to the myocardium is inadequate. And so those are kids where you may want to think about what's going on with your PVR and your SVR in order to give them supraphysiologic pressures so that they can maybe get a little more volume in during that short diastolic filling time. Other questions on this? Can you see this slide here? You see these here? This is a great quote. 1977, the British Medical Journal, when using a sphygmometer, so a blood pressure cuff, we pauperize our senses and weaken clinical acuity, right? Arterial lines are amazing. Invasive lines give you so much data. And I just want to show you this grid here to give you a sense of this. Here's pressure and dynamics. So blood flow and blood pressure on the two different axes, okay? High blood pressure, hypertension, normotension, hypotension. This is blood flow, hypodynamic, normodynamic, hyperdynamic, okay? This is what, by a blood pressure cuff alone, you can see there's 9 quadrants. There's only 2 that are normal, and all the rest are abnormal, okay? So you can have a normal blood pressure and be in compensated shock. You can have normal flow, but be hypotense or hypotense. So again, it's this coupling of pressure and flow, pressure and to understand what is the resistance through circulation, to decouple these things in your mind. And this is what echo does. If you think about it, this is what echo does. Echo tell you the volume of blood going through something. No, it doesn't. We ascertain that a ductus has a big shunt because the left atrium is enlarged. We're not making that assumption by the amount of blood we see going through the ductus. We're making that assumption by the anatomic change of the left atrium. You see what I'm saying? We're making these secondary assumptions by echo, but we often we couple these assumptions incorrectly. Okay, so just because you have a big ductus doesn't mean you have a lot of flow through it. Absolutely not, right? If you equalize the PVR and the SVR, what's the flow through the ductus? 0, no matter how big the ductus is. And so as you're learning echo and as you're thinking about the clinical impact of the pictures you're getting, keep that in mind. What is it you are actually measuring? Okay, when we measure function, are we really measuring how much force the heart is squeezing at? Nope. We're measuring how much the muscle thickens. And then we're using that to make an assumption that that thickening is translated directly to a force. We have a few more minutes here, so we're just going to kind of chat about some kind of pitfalls of echo that I see and that I hear about. This is just 2 weeks ago. We had a single ventricle, really bad mitral valve regurg, really bad tricuspid valve regurg, is a single V, with moderately decreased function. Okay, and we can't get the kid off milrinone, and we can't Lauren, you can drink your Coke in front of us, I don't care. And we can't get him off positive pressure. And then I just keep hearing from the group, they're like, well, his function is only moderately depressed. Is that true or not true? The echo says his function is moderately depressed. Clinically, is that accurate? The echo is telling you it is true. Based on echo standards, that his fractional shortening was 30-something%, 40-something%. Clinically, is that accurate? Well, it's not. It could be wildly off because it's only showing you how much the muscle is thickening. I'll get to this question here. It's only telling you how much the muscle is thickening, and it's only thickening in relation to the amount of pressure or resistance that it has to push against. If you have mitral regurg, everything can regurg right back up into a very low pressure right atrium or left atrium, right? To a common atrium. So it's very easy for it to thicken because the blood just goes right back into the atrium. So thickening doesn't tell you really as much about function. So anytime you have AV valve regurg, you ought to be hyperdynamic. If you're not hyperdynamic, your function's actually low. Because if you think about it, with every beat, blood's going back into that ventricle, right? It regurgitates back in, and you're auto preloading, you're auto bolusing that ventricle with every beat. If it was me and you and I gave you a little bolus with every beat, you'd be hyperdynamic. That is the definition of running, right? Your stroke volume increases and you're hyperdynamic to pump it all out. That's what's going on. So when a kid is normal function and they have AV valve regurg, the function really isn't normal. And so the echo report might tell you they're normal, but you got to keep a wary eye on those kids because they're underestimating their function. All right, Christoph Schwartz, thanks for the fantastic session. I'm going to frame this on my wall. Get a good comment now and then. We don't get them a lot in the cardiac ICU. It's a rough sport, as you know. In preterm infants, I usually do not see an isolated ductus. Most infants have relevant interatrial left to right shunts as well. Okay, we're going to spend the last 10 minutes. Perfect segue. What determines shunting at the atrial level? Shunting at the atrial level is determined by what?
Ventricular compliance.
Very good. It's not pressure difference, it's ventricular compliance, okay? So normally which ventricle is less compliant, is more stiff? Normally it's the left ventricle. In neonates, it's going to be the right ventricle for a little bit of time, right? But that's simply because the right ventricle was the left ventricle. It was directly connected via the ductus to the systemic circulation. All right, so it's the relative I want to add just one thing in there. It's the relative compliance between the two ventricles. All right. Christoph, can you talk more about, so are you talking about how do you determine left to right shunting if you have an ASD? Is that the question? I think it is. I'll give them a little minute to type while I'm kind of going through this. These are two separate phenomena. Atrial level shunting is determined by relative compliance of the ventricles. Ductal level shunting is determined by the relative resistance of the circulations. If you stick high resistance on the right ventricle over time, the compliance will get worse. Okay. And a TET's a great example of this, of what happens. So you get a TET, so you have right ventricular outflow tract obstruction, you've got a VSD, you've got an ASD, you may or may not have a ductus, okay? Usually not, but we'll call the VSD kind of that shunting at that level. You repair the TET, you relieve all the outflow tract obstruction. So the resistance from the right ventricle out to the pulmonary circulation and the resistance out to the body is normal. Okay, it's totally normal. The resistance is now normalized. If you get a TET back from the OR who's a really sick muscle-bound right ventricle, what direction are they often shunting at the atrial level? They come out and they're citing 85%, and they left a little ASD, the surgeon did. You're probably going to see right to left shunting, probably right to left shunting at the atrial level. You still have an intracardiac shunt. So even though the resistance is totally normal, the right ventricle is still non-compliant because it was muscle-bound pre-op and it hasn't relaxed yet. And so you still have this right to left shunt at the atrial level. And so they're blue from it. You get their lungs optimized, but then your game is to optimize the compliance of the right ventricle. Put them on the lowest PEEP that you can get them on. Decrease all the afterload on the right ventricle that you possibly can. Slow down that right heart so it has time to fill up. So instead of being stiff and underfilled like this, you give it some time to fill up and it relaxes and it gets to a more favorable point on the Starling curve. Remember, if the ventricle is empty, the intraventricular pressures are high. If it's full and full of fluid because it's not ejecting at all, it's high. But when you get it right in the right spot, it lowers. Okay. And so you got to get it to the right heart rate so it has time to fill up and relax a little bit. And so let's say you have a coarc. We'll spend the last few minutes on this. Let's say you have a coarc. Would you rather have a coarc with an ASD or coarc without an ASD? Which one is going to be more sick? Potentially more sick? Let you just mull it over for a little bit. I love coarcs, by the way. You've got a ductus, you've got an ASD, sometimes they got a VSD, super fun physiology. And anytime, what I want you to feel is anytime you have a ductus or an ASD or VSD, you are now empowered to dominate a resistance in one system or another and to give yourself some extra systemic or pulmonary blood flow, depending on what you want to accomplish. But you can kind of, I call it cheating the shunt, right? So let's say you're going to, as you're mulling over this coarc, let's say you're going to intubate a kid with a ductus and he's super, super blue. What are you going to do to keep the kid from getting so blue while you intubate him? Ooh, good answer, Renee. Good thought. Right answer, maybe not the right exact reason, but good thought. Love it. Right? So your whole goal when you're intubating a sick kid with a ductus is to drive up their SVR, right? So you promote more left to right shunting, more pulmonary blood flow. Same with an AV canal. Same with the VSD. You just drive up their SVR and force all that blood to their lungs during that period when you're inducing them. So typically fentanyl, Versed, whatever you want to intubate with drops their SVR. So when I intubate kids with pulmonary hypertension, if they have a ductus and intracardiac shunt, before I ever intubate them, I'll put them on either norepi or vasopressin or phenylephrine or something to bump their SVR way up and keep their sats up there as I'm giving them those other meds so their SVR doesn't drop. And then if they get blue during intubation, I give them a little epi spritzer or a little phenylephrine bolus and their sats go right back up again. They might not have as much cardiac output during that time, systemic output, but I preserve their saturations and their myocardial oxygen delivery during that moment. And usually they have enough blood flow overall. Let's say you had a TET, neonatal TET, okay? And you're trying to put an art line in and it's really difficult. You can't feel a pulse. You can't get a good reading. What can you do to improve your ability to put an art line in a TET? Let me ask it another way. What can you do to improve their systemic output? It's kind of counterintuitive. You make them really blue. Make the TET really blue. Turn their oxygen down, and they'll shunt more blood to the systemic circulation, and you'll get a pulse. Yeah, you're going to get a better pulse because you have more blood volume now going to systemic circulation. So back to your coarc ASD, we'll end on this. So if you've got an ASD and you've got a coarc, the resistance is going to be high on the left side, right? Correct? Your left ventricle may be less compliant as well if it's a 5 or 10 day old coarc because they've been fighting this coarc now for 5 or 10 days. It's a week. So the left ventricle is going to be more stiff. So you're going to have more output going. At the ASD, it's going to go this way because this compliance is going to be worse than this compliance. So you have more blood flow going there, more blood flow going this way, more going this way, more to the lungs, right? Back to here, back to here, back to here. So now this kid is congested through the ASD, maybe also congested through the ductus with less cardiac output because more of it's going across the ASD to the body. So this coarc can be significantly more sick than a coarc with an ASD than one without, because they can just stick more and more blood to their lungs. They can raise their QP through 2 separate shunts compared to a coarc who's only got 1 ductus. Make sense? Does that answer that question, Chris? It's tough to gauge how you guys are doing over a video chat. I apologize. I hope I haven't gone too fast or too slow. I know we didn't have a lot of echoes today, but to me, this is how to make echoes make sense.